This is Dr. Mobeen Sayed from drbeen.com. Today I wanted to look at some of the medicines and the drugs that we had already been talking about and look at their latest status. So the drugs that we will talk about are the Ivermectin, Remdesivir, and Leronlimab. And pay more attention to Ivermectin because there is a preprint, so it is not a peer-reviewed and published study yet. It is published, but it is a preprint yet. Pay attention to the the Ivermectin there. They have shown that it works in the late stage of the disease as well. And remember, Ivermectin is not an expensive drug. Compare that to the more expensive drugs, which have not yet shown that much of an efficacy. When I look at my patients, I have now very good success with hydroxy and ivermectin. And I feel that sometimes combining them is even great. And sometimes ivermectin actually works faster. And so keep that in mind and let's start our discussion. I'm going to share my screen. So this is a study that we had already seen. This is about the ivermectin inhibits the replication of SARS-CoV-2 in vitro. So remember that when we talked about ivermectin the first time, this is the study that we had used. And I just want to give us a quick look at it. Now, the other study that we have, let me show here. So an important note about the ivermectin, and that is that ivermectin should not be given to anyone who has an issue with the blood-brain barrier. That means the patients of meningitis or pregnant women. So the woman herself is not at risk, but once she takes the ivermectin can cross the blood-brain barrier of the child, the fetus whose blood-brain barrier is still being developed and can cause permanent brain damage. Similarly, ivermectin should not be given to lactating women. Again, not much risk to the woman herself, but ivermectin can be secreted in the milk, and then the child who is feeding still has the blood-brain barrier being developed, and it is possible that there is brain damage that can occur. So keep that in mind. Now, there is for the ivermectin, there is a study which is a retrospective study. So again, it is a retrospective study. It is a preprint yet. The study name is ICON study, and here is the medRxiv where the study is. What they did was, and look at this study is between March 15 through May 11. So what they did was so this study was done in Broward Health Hospitals, 4 of them, March 15 to May 11. There were 280 participants in the study. Out of those, 27 were not reviewed. 173 received the ivermectin, and 107 did not receive ivermectin, or they received the usual care. The decision to give the ivermectin was not the decision from the authors of the study. This is a retrospective study. They were looking back at the data and record and collecting the data. So it was physicians who were deciding what best way they wanted to take. So some physicians had prescribed ivermectin and some had not. So the result is fascinating that in the ivermectin group, the mortality rate was 15%. And compare that to the other routine care, mortality rate was 25.2%. So that is a significant difference, 15% mortality versus 25.2% mortality. The dose of the ivermectin given was 200 microgram per kilogram, one dose, or in 11 cases, in 11 patients, there were 2 doses given because they had stayed in the hospital for 14 days. So the regular dose for ivermectin is, let me just take this caption off for a second, just one. The regular dose for ivermectin is anywhere from 150 to 200 microgram per kilogram. And usually for the deworming, ivermectin is given once in 6 months or a year. Then with this, there was Another group out of the same group here, actually this 173 patients, out of them, there were some patients that had severe respiratory disease. And please check this one out because this is a new thing for all of us. And it is an interesting thing. So 75 patients had severe respiratory symptoms. And what does that mean? They had the FiO2 requirement greater than or equal to 50%. So they were on oxygen and they needed a lots of oxygen, or they were on ventilation. So ivermectin, we're talking about ivermectin for the patients who are on ventilation or who has FiO2 requirement that is greater than or equal to 50%. And look at this, ivermectin 38.8% mortality, and look at this routine medication 80.7% mortality. That is a significant difference. So the important thing to note here, we have talked about ivermectin, we have looked at its mechanism of action. It is, I think you may know that YouTube had taken down the video once, then I had to re-record it and uploaded it again. So we have talked about the ivermectin drug itself in depth. However, this is the first time we are discussing usage of the ivermectin at a later stage in the disease. So if I go here for a second and just map out how we've been looking at the disease, COVID-19. So we know that there is a pre-symptomatic stage, then there is a symptomatic stage. And yes, we are aware that there are some patients that would stay asymptomatic or very mildly symptomatic, asymptomatic. So symptomatic stage, then it is possible that there are mild symptoms, there are moderate symptoms, and then there is severe and critical stages. The drugs like hydroxychloroquine have been looked at to help in this early stage, in this part. And that is where hydroxy has to be started early with azithromycin, with zinc, and we have done that discussion many times. Ivermectin for the first time is showing that it is interesting to use throughout. So on the ventilated patients, on the patients that are receiving oxygen, and on the patients who are not receiving oxygen or who do not have that much of the respiratory symptoms. And interestingly, on the general cases, look at the mortality rate, 15%. However, in case of the severe cases, where 80.7% with the regular treatment had the mortality of 80.7%, that compare that to 38.8% with ivermectin. So more than half of the patients were improved with ivermectin. There is a comment here, giving pregnant women hydroxychloroquine. So again, I'm talking about hydroxychloroquine in the therapeutic doses. The only contraindication for the hydroxychloroquine are retinal damage or retinopathies, cardiac issues, and the blood disorders, especially G6PD disorders. I have not heard of any contraindication for pregnant women for hydroxychloroquine, not for ivermectin. Ivermectin can be quite an issue. The other one thing that was there is that no significant difference in successful extubation. So extubation is that removal of the tubes once the intubation has occurred. So here is this study. I really loved it. Again, I want to make sure that we all know it is a preprint. It is not yet peer reviewed. The study name is ICON, and it is for ivermectin. So 280 patients, 107 were usual care, 173 were treated with ivermectin, 27 were not reviewed. And we have seen the result. Next is ivermectin has also been used in Dominican Republic. And that is interesting. This is not a study, but the largest private hospital group or health group in Dominican Republic has been using ivermectin. And look at their results. So this is an interview with their president of that group. And look at the discussion they've done. So they are saying that they have treated 1,300 patients. Let me see if I can zoom in a little bit. So 1,300 early stage COVID-19 patients that had dramatic results. So look at this, 99% of them have been cured. And this is an interesting thing. So let me go here for a second and discuss what does this mean. Look, let's take China's data. China had said that by March, so this is their data by February something from December, they had said that 81% of the patients usually recover without any serious medical intervention. And then 19% of the patients are that end up in serious situation or that end up in critical cases, and then out of them, some of the patients die as well. So if there is a drug that gives us efficacy below 80%, 81%, that means it was really in the placebo range. 81% of the patients were going to become okay anyways. So that drug was there or not there doesn't matter. Or if there is a drug that gives us similar results as up to 81%, I would call that drug as well as placebo if it has not made any significant difference compared to a patient who did not take anything. However, if there is a drug that goes beyond 81%, so let's say it is 90%, it is affecting and protecting 90% of the patients, that means that drug has taken care of this extra 9% who otherwise were going to have serious situation. That is the case here as well, that the 1,300 patients who were treated, 99% were cured. So now the question for us to answer will be, in Dominican Republic, what was the normal death rate? And that is so the data, 32,000 cases, 747 deaths, 2.3% is the death rate. So here, when they used ivermectin, the death rate was 1%. So definitely there is a better outcome. So this was another important thing to discuss. So look at this here. 99% of them have been cured. The average duration of the full infection went from 21 days to 10 days. This is also very important to note. The drug starts inhibiting the virus within a couple of days in human. We know that from this original study that within 24 to 48 hours, ivermectin starts working. The only side effect have been mild heartburn and diarrhea. So I will say once again, not for the pregnant women or people with meningitis. There were a couple of things that were interesting for me. What is the treatment amounts? Well, we started with so this is the interview with the president of that chain. We started with what is in the standard antiparasite protocol of 100 to 200 micrograms per kilogram and have progressed that to 400 micrograms per kilogram of the body weight. And they also included azithromycin in it. So almost double the dose of the regular and deworming dose. So patients, we talked about it. Have there been any adverse effects, heartburn and diarrhea? We talked about that. And then this is another interesting question and answer. So the interviewer had asked that, hey, have you been contacted by anyone in the US? And the president of the chain said that, yes, doctors from US have been in contact and they've been using it while it has been kept a secret. So I think this next one, the next question and answer really tells us what's going on in the market out there. And this is not something that I need to explain it. This has been discussed a lot already. And that is, on that note, so the interviewer is asking, why do you think that is? Why is it kept a secret? Well, economics. The big drug companies cannot really profit off of a generic drug that is in use worldwide for treating parasites. A key along with the vaccine is to work to treat the disease early, stop it from progressing to a more severe state. And this is my discussion all the time with my patients as well, that in the early stages, patient actually feels that I'm fine. I just have occasional cough or maybe some breathlessness. I'm okay. And they do not want to take medicines that's saying that, hey, we're okay. And possibly 81% of the patients without any serious medication will become okay. However, our approach has to be that right in the beginning, you start managing in a way that they do not progress, or the risk of progressing towards serious disease is reduced. And that is exactly what I'm hearing from that chain's president, that he's saying we start it early and we try to prevent them to become serious. And the second thing he's saying is it is cheap medicine. So compared to the more expensive medicines, it is actually available, it is cheaply available, and it can be used. So that is what I thought that it was interesting. So what is the price of this drug? $38 for 3 6-milligram pills. $38 for 3 6-milligram pills. I do not know what is the price of this internationally. Is it more than this, or is it lesser than this? If you are watching it from some international country, please tell us the price for this drug that you see in your country. Because I am sincerely seeing, with my own patients, I'm sincerely seeing ivermectin doing much better even than hydroxy. And I'm not beating down hydroxy. Hydroxy I use as well, and it is a very decent drug. But even ivermectin is showing even better results. So there are many, many clinical trials for ivermectin that are going on. So we would hear more about this. But today's takeaway, cheap drug being used in Dominican Republic. There is a preprint of a study that showed that this drug is useful at a later stage in the disease as well. So that is very important. Now let's go to Remdesivir. So of course, Remdesivir and Gilead, and I have the pricing of that drug, the Remdesivir. I have not yet seen any decent study or even a preprint or even anecdotes that show that Remdesivir has done that greatly. I know that saying this would probably tickle these folks and they would start reporting this video, but I have not seen great results from Remdesivir. Actually, in some cases, I've seen the allergic reaction occurring to Remdesivir where it had to be stopped. So let's look at the original study that the Remdesivir Gilead had done, based on which they had received the approval to go ahead. So remember Remdesivir, we have done this discussion in the past. It is an adenosine analog. It's a nucleoside analog. And unfortunately, in that discussion, I called it a uracil analog. That was my mistake. 1059 participants in the study, 538 on Remdesivir, 521 on placebo. Median recovery time was 11 days for the patients who were receiving Remdesivir, and the median recovery time for the placebo was 15 days. I actually think that it would be interesting to compare this to ivermectin, whose recovery time is even faster. Then mortality estimate by day 14, 7.1%, and mortality as estimate by day 14 in placebo group or in non-Remdesivir group, 11.9%, and so that is not a significant difference. This is a significant difference. Look at the price. Privately insured, so this is the prices in the US. Privately insured patients will have one vial for $520. And the whole course for 5 days, which includes 2 vials on the first day, $3,120. $3,120. What will uninsured folks in the US pay for it? That is not known yet. Outside of the US, the price is $390 per vial. And then again, for a 5 days course with first day 2 vials, $2,340. Expensive drug. I do not see enough. I haven't yet seen enough results from this that I can say, hey, this is a great drug. So that is the Remdesivir, and I want to show us some of the studies here as well. This was the original study, I believe. That was a preliminary report based on which they received the emergency authorization to use Remdesivir for critical patients. So this is that study. We have actually looked at that study, I think, in the past as well. What they had done was, in this study, they took 1,059 patients. I just talked about it, 531 and 521, and the results were here. So this is that study. This is Gilead announcing, so this is also interesting. Gilead has announced that they are starting another remdesivir trial as well. So if you see here, in this study, hospitalized patients with confirmed, so this is the old study. Their results were at day 11, a higher proportion of patients in the 5-day treatment group achieved improved in clinical status. So please now realize this. In the study, they had done 5-day trial and 10-day dosage. And only the patients that were in the 5-day treatment group, they showed improvement. The 10-day treatment group patients did not show improvement. Then there is one more thing here. I think I have highlighted it. They are starting more trials as well. I had highlighted that somewhere. Anyways, maybe not here. This is another one. This is the remdesivir. This is NPR. Remdesivir priced at more than $3,100 for a course of treatment. So this is where the price came from, $520 per vial, and we talked about it in a second ago. And now to the Leronlimab. I actually feel that Leronlimab is even more efficacious compared to remdesivir. It is also a nucleotide analog. It has shown promise in its original study. It is starting, so in the US now they're starting phase 2B and 3 trials for 390 severely ill COVID-19 patients. So that is the trial that they are starting in the US. I believe this was their original trial for the Leronlimab and the results of that. This is the trial that they are starting. So this is Cytodyne's own website. So I am looking at their website. Of course, their own website would be more favorable towards them, but I don't see any issue. I hope that we know when we did the CCR5 and CCX5 disruption. So it normalizes the immune system. It normalizes the ratio of the CD4 and CD8. So Michael Sheikh says wrong. They finished the phase 2B. Anyways, I am looking at what is the discussion here. So if I go to Cytodyne here, this is June 29, and they are saying that impressed that so this is the Mexico. They're starting a phase 3 trial here in Mexico on 25 patients. And if you see down here, a randomized clinical trial, mild to moderate COVID-19 population in the US, and enrollment continues in its phase 2B3 randomized clinical trial for severe and critically ill patients. So even if, who was the commenter here? Michael Sheikh, someone who was saying that they've completed it, they may have completed it. But even on the news, which is 29th of June, just a couple of days ago, their own statement with the press is that they are continuing to evaluate. So maybe they are still working on the data from the phase 2B and they've finished having the participants in that. So this is the discussion for today. I wanted to make sure that we look at ivermectin's effectivity for the late stage, and we look at remdesivir, which I don't see that to be that promising at this time, and we look at Leronlimab and see where it would stand. One thing that is missing in here in this discussion is the price for Leronlimab. I remember last time when we talked about the price for this one, it was, I quoted a very large price for the HIV or other cases, and somebody from their company or maybe somebody who was their stock owner, they had reached out and said that, hey, their price is not this, and their CEO would really love that if this drug is useful, then they would not be fussy about the prices. So considering that, I do not have a price model in front of me for them. I would suspect that if it is possible that it is good, then they may be able to give it for a lower price. We would see what happens. So now just a few questions and then we close for today. Abdu is saying that what about Favipiravir? So yes, so Favipiravir at least has been started in India. I need to see some results from that before I can comment that this is great or not. Maybe it is a great drug. However, I do not have yet some study, even a preprint or some sort of data coming out of the doctor's offices to see how it is working. One more thing that if somebody from India is listening, hydroxychloroquine, we would really love to have some data from them. I know that India has now, I think, administered hydroxychloroquine to 76 million people. And I believe they have seen good results. The question is there some data that can be put together that can be shown to the rest of the world to help them figure it out? So Michael S. ID correct. MP2 trial had IPV today. Okay, so that is good if the phase 2B trials are done. So this is very, very important question. So AG is saying, what about camostat mesylate? So I was thinking about that camostat mesylate is such a promising drug because it blocks the TMPRSS2, which primes the coronavirus's spike protein, and it is cheap as well. And it has been used in Japan for a long time. Why can't we start? There are many trials that have been started for camostat mesylate, but we are not getting much press about that. We're not getting much news about that. I think one of the reasons for that is that because it is in Japan and it has been, most of the literature is in Japanese language, I think we are not getting the translations, or we can't search it that easily. So if anybody who is listening from Japan, or anybody who knows Japanese language, or anybody who knows camostat mesylate's usage, please send me some links. I would love to talk about its efficacy. I am a fan of camostat mesylate, but I do not have enough data to share here. So there is a question here, what is the best prophylaxis replacement of HCQ zinc if that is being blocked from US? So look, I believe that ivermectin once a week. This drug normally one dose for 6 months or a year. So in this study, ICON study, they gave one dose per week. So ivermectin can be a good prophylaxis as well, once a week, 6 milligram tablet. And again, I'll keep repeating, pregnant women, lactating women, patient of meningitis should not take that because it can cause permanent brain damage. Good question. So Sapan Singh says, you had promised a separate talk on doxycycline. Will do. I can do that. Kathleen is saying, what is camostat mesylate? So Kathleen, I had done a video that I believe the title was a virus blocker camostat mesylate. Please watch that. It is a drug that has been used for some of the autoimmune diseases in Japan. In Japan, it blocks TMPRSS2 protein on our cells. That protein primes the coronavirus S protein to allow it to bind with our cells. So this blocks that binding process. So it is a promising drug. And it is very cheap as well. It's quite cheap. It is same way like hydroxy or ivermectin. It is in the same price range. So there is a, Mark Andrew says, Leronlimab and Cytodine seem to have the solution. Just wish they could get approval from the FDA sooner. So that is the surprising thing for me. Remdesivir has gotten so much approval. They are everywhere. Leronlimab has to only allow, they are allowed 390 patients trial in the US, 25 patients trial in the Mexico. So it looks like they are kind of behind. I would love them. I would say that they should start their trials in India, in Pakistan, in other countries as well. Again, what I'm not sure is what is the price range they're looking for. If their price for Leronlimab is going to be even higher than this 3,000 for Remdesivir, then I feel that there may be a resistance to the drug. Why are you more excited about than Remdesivir? Because I'm not seeing the Remdesivir to be as effective yet. And I do not have much about the Leronlimab either. I understand that. However, the mechanism of action with the Leronlimab is much more interesting, or I have seen the studies or the data that I said and the mechanism of action that I saw, Leronlimab is doing very good as well. However, price can be very prohibitive. If the price is high, then it's not going to fly. So there is a, Michael Sheikh says, Leronlimab phase 3 severe trial has 122 enrolled out of 390, and they might have an interim readout. Very good. That'll be awesome. I wish that they can tell us the price that they want to quote. Without the price, we have no idea. If they're going to come in and say $20,000 for the course, that can become prohibitive for some. Of course, when it is about the life of a person, all the money that is necessary will be produced, I hope. But there are so many families and so many countries that cannot afford that much of. I would say that if that is the case, and hydroxy plus ivermectin maybe, and maybe even chemostat with that, that may become a better protocol compared to rem or leron. So there is a comment from Michael Sheikh. They said leronlimab would cost 6,000 for the treatment. It was talked about on the June 1st. And that is a complete treatment. That still is high, but of course it's not in hundreds and thousands, so that is fine. So are you aware of a more update from, no, so I haven't yet heard more from Dr. Alam from Bangladesh about the ivermectin and doxycycline. But I have been using it for my patients and very good results. I love it. Leronlimab pricing seems as though it will be between 1,500 and 1,800. So I just saw that on 1st June, Michael Sheikh is saying that 6,000. Too bad Cytodine is too small of a company, and I will ignore that. So yeah, this seems to not getting enough traction, while I think that they have a decent drug. Second week of treatment. Cytodine, Leron has said 1,000 so per injection. So okay. So there's a comment that here in Bolivia, you can get ivermectin 6 milligram capsule for about $2. Yeah. So there is a So there's a question that, in your opinion, when could leronlimab be approved and out to help patients? If it is, look, I think it is more of a people convincing the FDA as well, because the data that they have is promising. And so they should be able to push, but I do not know why their scale is smaller at this time. Is it their management? I actually wanted to talk with the CEO of the Cytodine and have them on our talk here. So if somebody knows them, please let me know. I would love to have a talk with them over here and see what their strategy is and why are they not getting enough traction. So the quick update on the vaccines. I talked about the vaccines about 2 videos ago. Quick update on vaccine. Now there are about 200 vaccines that are being formed. All kinds of vaccines, for example, the traditional vaccine, which is weakened virus, or the pieces of the virus, or the virus injected into the virus RNA injected into the adenovirus or other viruses. So these vaccines are out there as well. Out of them, Oxford's vaccine has been getting a lots of traction. They're getting a lots of money as well, and they are going to start delivering. So they are, I believe, in phase 3 in UK, and they have started phase 3 in Brazil, and they have started phase 3 in South Africa as well. In UK, I think they have enrolled 4,000 or more participants, and they're looking for 10,000. So I feel that Oxford has a good traction. Similarly, Imperial College came up. So if we compare the Imperial College with Moderna, remember in Moderna has this lipid nanoparticle in which they have the viral RNA, and the particle is injected in the body and the particle goes in the cell. Over there, the particle is taken off and the RNA comes out, and the RNA is then going to make spike proteins. Those spike proteins are then presented on the cell, and then immune system responds to it and becomes trained. That is Moderna. Imperial College has a similar technology. They have a lipid nanoparticle as well. However, the RNA that they are injecting in that nanoparticle has an enzyme attached with it, with that RNA. So when the RNA is given in the muscle, that enzyme helps amplify the RNA in our muscle cell. So instead of amplifying it out in the lab and making large doses, they are saying that with 1 liter of the material, they can actually create 20 million doses, because the amount injected has to be very small, and the rest of the amplification occurs within our muscle cell. And so because of that, that is going to be cheap. So Moderna is going to be expensive. Compared to that, similar technology, Imperial College vaccine is going to be inexpensive. I believe Oxford is going to be inexpensive as well. And then Sinovac in China is also doing good. I saw that India has also created a vaccine, and they have started as well. So I have to read up a little more on that too. So that is a discussion. So there is a comment here. Leronlimab showed that it was promising in the initial trials. Yes. So I've talked about those initial trials as well. So thank you very much. And there is a question. Hi from New Jersey. Love all your videos. Thank you very much. You're very informative and helpful. Thank you. Look at my software is really broken. Look, man, somebody say my software is broken. Sir, any news about statins regarding? I haven't talked about statin. My next discussion that I want to do is about the long haulers, the folks who become, who get the disease and they become okay, and then they have an underlying cough or fever or fatigue for months to come. So this is the discussion for today. I wanted us to look at ivermectin, leronlimab, and remdesivir. We'll continue our discussion tomorrow. See you tomorrow. Meanwhile, can you please do me a favor and like, subscribe, and share this video. I'll see you tomorrow. Bye-bye.